I'm Dr. Monica Gandhi, Associate Chief of the Division of HIV, Infectious Disease, and Global Medicine at UCSF. And today we're going to be discussing the effects of the BQ.1 and BQ.1.1 subvariants on COVID treatments. So this is the latest data from the CDC, and you can see at this point that the prevalence of subvariants around the country is really growing in terms of BQ.1 and BQ.1.1 prevalence. In fact, only about 11% of strains are BA5, and over 40% are BQ.1, BQ.1.1, with a smattering of BA.275 and XBB. And when we think about the lineage of the emerging subvariants of Omicron, really think of BA2 as being kind of the parent, and then that's divided into BA4-5, and the offshoots of BA4-5 are BA7, BQ1, BQ.1.1, and then another major family is the BA275, and its offshoot is XBB. This is really to say that all these subvariants of Omicron are emerging, they're more transmissible, and there are impacts on the monoclonal antibodies that we can use. So in terms of the monoclonal antibodies, unfortunately, we really have it sort of increasingly lost them as these mutations have emerged in the spike protein that render our old monoclonal antibodies pretty useless. And in fact, on November 30th, bemtelovimab, or BEB, was sort of taken away in terms of its EUA status because the subvariants of BQ1, BQ.1.1, XBB, which are now dominant in our country, really BEB does not work against them. And then what about the prophylaxis agent of tixagevimab and silgavimab? I'll refer to that as Tix-Sil. Well, essentially in vitro, if you look at these subvariants that are dominant, this particular Tix-Sil monoclonal antibody for prophylaxis does not work against these emerging subvariants. So here, this really shows you on this slide, what are the remaining treatments that we have for COVID-19 in the face of these subvariants that are predominant. And actually, we do absolutely have three options. The first is essentially the protease inhibitor. So this is nirmatrelvir with ritonavir. They are administered separately, and this is really a BID or twice-a-day regimen for 5 days, unless the glomerular filtration rate is below 30, in which case you want to give it once a day. This 5-day course of this protease inhibitor is not disturbed or perturbed by the subvariants. It still works very well. This is an oral treatment for outpatient treatment. The second is remdesivir. Remdesivir we do give in the inpatient setting, but it's also been approved for outpatient treatment for all of the emerging subvariants. Absolutely works, and we can give this down to very low kilograms. Essentially, we have to change the dose, obviously, if someone is between 3 and 40 kilograms is indicated here, or above 40 kilograms, and this is an outpatient therapy, but given as an infusion. And then the third is molnupiravir, and this is a nucleoside analog that is also effective against the subvariants. One thing to say about all of these is the protease inhibitor really and the molnupiravir drug have both been studied in randomized controlled trials in those who are unvaccinated at risk for severe disease, and they showed very high rates of prevention of hospitalization and death, actually 89% protection from hospitalization and death. For nirmatrelvir and ritonavir, and for molnupiravir was 30% reduction in hospitalization and death. The data that we have among vaccinated patients are really from large observational databases, and at least for the protease inhibitor, those over 65 benefit the most in a large Israeli study published in the New England Journal of Medicine. Molnupiravir likely doesn't, at least for those less than 65 in the Panoramic UK study, doesn't seem to improve hospitalizations and death for those who are vaccinated. So I'll just say in my own practice, the loss of the bemtelovimab EUA on November 30th has affected the way that we think about treatment. We are very fortunate to have 3 remaining treatments used for outpatients, though BEB was very useful because it could be given as a very rapid push. But essentially, we're moving now more to giving out the protease inhibitor the nucleoside analog, Paxlovid and molnupiravir respectively, and we definitely have restarted our outpatient infusion of remdesivir, especially for those younger patients, since the 2 oral medications are not approved for younger. So it has affected us, but we still have options left. Thank you so much for joining me today. And for more information on COVID-19 treatments, please visit the series landing page at exchangecme.com. And the latest updates on COVID-19, subscribe to Exchange CME's YouTube channel and check back regularly. Thank you so much.